All right. Well, good morning from North Carolina, or good evening, as the case may be. It's Monday, Martin Luther King Day, which for many, many people in the States is a holiday celebrating someone who had a dream, pursued the dream, and tried to make a difference in the world. So we're all about that. So we're doing a day dedicated to service as we move into 2022. So I thought I'd show, I mean, you can't really see a lot. I'll pull back the curtain. You probably still can't see a lot. Our snow from yesterday, I think you just see glare. Our snow from yesterday was brief, but on top of that, we got a good bit of sleet, like several inches of sleet. And then at the very end, it started to turn to rain. But then the temperature dropped back down below freezing, just below freezing. So Matthew, what do you think that means? Come here, I'll let you, come on. What do you think that might mean in the world of transportation and travel?
Yeah, it got pretty treacherous around there, I'm sure, because all that turned to ice and got pretty slick.
Sure enough. So what did y'all just see? What popped on the screen, even though you can't see the outside weather?
Yeah, we got to see Benji and Braden are still with you. So they didn't go home yesterday. Yeah.
They did not go home yesterday. They did not go home at all. No, it was night 2 at Nana and EPAPS, because it was like, it got a little too risky for all our preferences, especially since the Highway Patrol in North Carolina was advising people to stay off unless it's an emergency. And our driveway is like a sheet of ice, because all the rain did was cement the sleet crystals to the base, so that now we have a very nice skating rink down the thing. So I've got a feeling they'll go really fast on the sled. I'm not sure how the trek manager getting back up the hill is going to manage until it warms up. So anyway, so that was our surprise for the evening. So what are we going to talk about today? Well, we're not going to talk about Braden and Benji. Someone last week had identified that I had indicated I'd done a talk for medical providers at UNC and the surrounds on, so you give a diagnosis, what prescriptions should you be giving? And, what was fun, was interesting also, was that many of the providers who are knowledgeable providers said, yeah, it's real tempting to go to the meds that we know instead of the situation that's in front of us. And so I went through, like, what's the best practice as far as what we know from the perspective of people living with dementia, because I've certainly gotten that input, but also my experience at working with people after the diagnosis for many years. And what are people looking for? And so we thought we'd spend some time this week exploring that. Like, so after the diagnosis, what comes next? What are we looking at for medical providers? What do we need to learn more about as supporters of people living with dementia, so everybody gets what they need for a better quality existence? So right off, Matthew, I'm just going to ask the question I asked them. What's the most common prescription that's given after a person, when and it's not after, when they get the diagnosis? So the doctor finds out, it looks like you have a dementia. And so here's what we're going to do.
Okay, so
what do you think it is?
So I'm curious, Teepa, because you said, what's the common prescription? And it sounds like you're also looking at potential or common suggestion right after that. So not necessarily something.
Yeah. So usually physicians come up with a care plan.
Right.
And some of it is actually pretty formal, like a prescription. Mm-hmm. And that prescription could be for treatment, could be for further evaluation of anything. It could be for a medication, because all of those require what we consider a prescription. They have to formally move it forward somehow. And so they have to prescribe it for the individual. And that's the thing about medical providers. They prescribe things.
So,
all right. So what do you think? Given that, what do you think?
I would say, that care plan piece setting that care plan up. So I have a feeling they would.
Oh, Matthew, you are so mistaken. That is not the first thing that typically happens.
So, well, and I guess for me, my first real thought was if there was a medication that they could give, that would be the very first thing that they'll.
What's the one they give them right off? What they give people just sort of off the very cusp from the very beginning when the diagnosis happens? What do they go to on that prescription pad?
Okay, so all right, I know we've talked about this Teepa, but I know Aricept pops into my head.
Any kind of acetylcholinesterase inhibitor.
Thank you. Yeah.
So that generic acetylcholinesterase inhibitor. In other words, something to try to. Now, this is the tricky part. Something that we're going to try to, and now finish that sentence. Why are we using this med? This acetylcholinesterase inhibitor. It includes dizipramil, things that are classically the acetylcholinesterase inhibitors. I'll give you the brand names most people know about: Exelon, Aricept, and Razidine. Those are the three that people know most frequently, and the generic names of those are available. We could get into that, but the bottom line is that's the most common med. Why do they tell people they are giving it to them?
So,
the most common statement made.
To help them manage the diagnosis or something else. I see that.
Nope, that's not the most common statement made.
No, I'm very curious, Teepa, what that common statement is, because I'm
to
thinking
slow the disease down.
To slow it down. Okay, yeah. For me, symptom management. Why medication is given is for symptom management usually, or potential cure. But if it
so
is,
for me, there's a disconnect between truth and fiction right from the very beginning then, because none of those meds are designed to slow dementia down. What they're designed to do is help with the potential of acetylcholine activity. And so if your acetylcholine is reduced, if you don't have as much acetylcholine moving around in your brain, then the introduction of acetylcholinesterase inhibitors potentially for some people might allow more acetylcholine to get where it could go, which means the best that you're looking at is maybe some symptom modification. But we should be aware that some symptoms of a condition that affects your brain might be that you are less concerned about things, less anxious, because acetylcholine raises your level potentially of emotional distress. It affects your cardiac system. It affects your stomach activity, your ability to eliminate without a lot of false starts kind of thing. So, some of the symptoms you may be having due to the reduced acetylcholine availability might not be the ones everybody's thinking about. Now, the not being able to hold on to details as well about new stuff, the not being able to come up with words, the not being able to stay on task. Some of those might also be symptoms you might be trying to work with, but that would require that we look carefully at what symptoms the person is describing and their partner might be describing, or their other might be describing if they brought another, to see what symptoms are bothering them about their condition. Because, just even recommending that med, if the person isn't complaining about those symptoms and you give the false information that it's slowing the disease down, boy, that's sort of starting off, to me, it's starting off on the uh-oh foot, because it's like, okay.
So Teepa, I'm picking up on something here. This idea of, the going in to the doctor's office, getting the diagnosis, and then they prescribe, if one of those first things that they do is prescribe this medication, that being curious and finding out more about these medications could be helpful to see, because, we have some folks who are putting some stuff in the chat. And one piece that was in the chat was this part that someone said that their mom had suffered from stomach issues for years because she was so desperate to try to slow down the progress of the diagnosis. So the idea of being aware what this could do, knowing what the medication does and knowing what it could do, because you might have to ask the doctor, or you might have to, say, hey, my mom already has a stomach issue. Is this going to make that worse potentially? I read that.
Yeah. And not only that, but cardiac issues. So people who have cardiac issues have to particularly be tuned in. Now, again, really skillful physicians might explore that. The problem right after getting a label, because that's when we talk about a diagnosis, it's more boom, let me smack you. For many people, and for other people, it's confirmation of, and I'm going to say it like this, and then we're going to back it off, a nail in the coffin. It's like, oh, I was afraid of that. Ugh, God. So when that happens, the estimates are, and these are people reporting and being asked in a study, somewhere around 70 to 75% of people after that hear nothing else that's said.
No.
They can't remember anything other than getting that information. And I'm not just talking people living with dementia. I'm talking about the person who might be with them. All they really hear is, here it is, this is what you got. And so any straw or thing that is offered in that moment might be misperceived, misheard, misunderstood. You might not even be thinking about your answers because you've got an emotional reaction to this. Okay. So I just wanted to lay that out there because that's the most comfortable thing for a physician or somebody who's a physician extender or somebody who's a nurse practitioner, whoever's comfortable with meds. That's the one that people tend to go to. But the statement that this will potentially slow the disease down. This is the one thing we have to try. This is something we can try for symptom management. Let's talk about what symptoms are, really, if you want to go further, but the bigger picture is we shouldn't be having any of those discussions yet. And what we should be doing first is, did you finish and did you actually get to a diagnosis, or did you get to symptom identification and syndrome identification? That you've eliminated other options. So you're pretty sure that what you're looking at is some form of neurodegeneration that's not fixable. That might be either due to an abnormal protein buildup or a pathology that's causing neurons to have neurofibrillary tangles, or perhaps you're looking at something that might be more causing issues in the deep brain and on the cortex, synuclein protein malformations, or maybe you're looking at something that is more vascular in nature, or health of nourishment and blood vessels and oxygenation issues, like, some of those kind of things. Or was it just simply that, it's some kind of dementia, probably quote unquote, the big one that everybody talks, the big A. And instead, was there actually a diagnosis? Or was it just identification of a syndrome? Okay, so then let's back it up a tiny bit more. And my question to everybody is, do you remember why the person came to you in the first place? Do you know why they came into you to get this quote unquote workup to start with? Are you recalling what their mindset was prior to you starting this investigation of yours? Because how I come into this should determine what we're going to do dance-wise after you determine that you think I have some sort of neurodegenerative condition that's going to be an ever-changing disability in my life and will eventually, all things considered, might either quickly or slowly take away a lot of my abilities and replace them with things that I don't currently see as things I focus on and do as part of giving me purpose and value in living and pleasure in being alive. So do we reflect back and remember why people came in? And so what I did with the group is say, now there's a variety of reasons people might come. And some of them weren't started by the person that you're identifying as having the condition, by the way. Because it's possible the person is unaware of things that are shifting and changing for them. Or it is possible that the other health conditions the person has are the thing that are bringing them in. And that actually happens quite often. And so what you're not really thinking through is if it's the other health conditions that are the biggest challenge, then really putting your thinking cap on is, okay, so how is having dementia as a condition in combination with these other health conditions going to impact your idea of intervention and support for this person? Because now you got to think through, okay, well, where are they in their dementia? Because I think that brain changing thing is what's going on. And how much of the challenge of managing the other health conditions is due to the problem with their brain. And so, this is going to require some more thinking and some more planning, which is not a bad idea at all. So let me give you sort of my laundry list of what I think the reason people might be coming to see you is. Okay, so I'm going to share my screen because I actually have it on a PowerPoint here. So they come because of non-dementia related health concern. Maybe they broke a hip. Maybe they had a fall. Maybe their blood pressure's all over the place. Maybe they have depression or mania. Maybe they have cardiac conditions that are causing hypertension. Maybe there's diabetes involved. Maybe there's Parkinson's involved. So maybe there's a health concern. And they're coming to see you, and you, while you're working up the health concern, identify, in addition to that health concern, I think we have neurodegeneration going on here. A second is perhaps a depression or anxiety issue has reappeared or arisen for the first time. And so we have a health condition that has never been addressed or has been addressed in the past as a health condition. And we might get sidetracked into thinking the primary issue is one of those two and forget that how important it is to associate dementia, the type of dementia and the possibility of one of those two happening at the same time, and coming up with a care intervention and a plan of action that's going to take both of those into consideration, not just one or the other. So there's a possibility that there's a family member or a friend who just recently got involved in the person's life and all they think is something isn't right and they wanted it looked into. I mean, they thought something was going on, but they don't know what it is. So, whoa. So this person is just now figuring out that something's not quite right. They weren't anticipating something like a dementia. They just thought maybe the blood sugars were off, or maybe, mom's really sad since dad died. Maybe, they just recently are involved. So they don't really know the baseline and how the person got where they are. And the person may or may not be able to be accurate about that. Perhaps somebody's been involved in somebody's life and finally got the person that you're seeing talked into seeing you. I mean, it could have been a lot of work to get somebody in to see you. And perhaps they have other health providers, other providers who are treating different things, and they were not getting satisfaction. And so they finally came to see you to see if you could help. And then we have the group where the person themselves is the one that thinks something's going wrong with their abilities in their brain, and they came for answers. They want to know what's going on. And then there might have been somebody involved and they want to know what type of dementia they're working with or living with. So it's not like a brand new thing. They didn't come in for a syndrome. They came in for a diagnosis. So Matthew, I'm going to pause there because I think I've thrown plenty out here just for us to get started. What are we thinking?
Yeah, no, I agree, Teepa. And we have a lot of activity in the comment thread. A lot of folks sharing stories, sharing situations.
Yep.
talking about that piece of being curious about medications, but also noting that for some of them, the medication that was given, for instance, for someone whose husband was having hallucinations, that it was helpful, but yet their mom ended up with the same medication and it was not very helpful for her. But that idea of staying curious with meds, noticing, okay, this isn't quite working like they said it should, or it doesn't seem like it's helping and things don't seem as good as they should be. Let's ask questions and let's see if there's something we need to try different. And then we have folks who are sharing about different types of dementia and this idea. So looking at some kind of vascular event that had happened. So like a stroke. And we had a question about that idea of, okay, so with that stroke, someone who's had a stroke and then has been diagnosed with a vascular dementia, could there be potentially a chance of it reversing? Like after 5 years, could there be some healing that can occur potentially, or some clearing that could potentially occur, that we could see some change in the opposite direction than what we noticed in the beginning?
Yeah. So that is a super duper and wonderful question. And one of the reasons we want to be smarter about this and much more detailed about this than people currently are, is that a lot of the hype around fixing Alzheimer's is more than likely actually fixing some of the issues related to vascular disease. And so it turns out that there are things called collateral circulation, which means there is another blood supply to an area of the brain that might not have been the primary blood supply. It was a secondary. It wasn't very good. It wasn't very healthy. And what ended up happening is after the stroke and after a period of recovery, if you get into, let's say, an exercise regime and a better eating and better taking care of your brain kind of situation and body, and you regularly do things that are good, you might actually see some improvement in abilities. Now, does that mean that you won't continue to have tiny little minuscule episodes of either flow reduction due to problems with oxygen or problems with nourishment or problems with whatever in the microcirculation or not? Well, we don't think we can't totally reverse things, but we can see a change in symptoms. Now, is that curing the vascular? Absolutely not. I mean, there is still damage. There are still areas that are white and dense, which means there's dead tissue in various places in your brain, but your function could change. And so this is where this gets tricky, because people love to say, oh, no, she's better. And I think it's due to my treatment. And it's like, yeah. How hard do you want to keep working? I mean, like things like having to get in a chamber, like for the bends, or, the lung condition that you get when you go diving and you get bubbles in. I mean, hypobaric chamber, how much do you want to do that on a daily expensive basis, or go in for some kinds of special or eat a special, do only these things? I mean, it depends on how much you're willing to commit your life to trying to stay on the high side. And for some of us, the amount of stress going into that would totally negate any benefit I would get from it. I mean, if I wanted to do that, guess what? I'd already be doing it. You make lifestyle choices that match you. I mean, and yes, I can do some adjusting, but if we have to be so focused on it, I'm really curious about the benefits. And I think we got it. The studies have shown that, wow, I'm not sure that's really where that's going. I mean, some self-study is one thing. And yeah, I mean, that could be, but so anyway, that's, when it comes to vascular, I think the hope is we can reduce the risk. We can buy time. I mean, that's what we're looking at, is buying more time. And I happen to believe that's going to be the case with a lot of dementias, because once we acknowledge what we're looking at and the kind of dementia it is, we can more put a plan together that makes sense. But this was our first session, and we've already taken up 25 minutes of your time. So I want to be tuned in. I will give you sort of a little preview. Okay, here's where we're, what we're coming in. This is what people are really, they want to get a diagnosis, and then they're actually looking for a prognosis. What does this mean? they wanted to not actually have dementia. And so what's happening for them is they were hoping to have something fixable. So they're having a really difficult time wrapping their head around this thing they have that isn't fixable. They might also in that moment be trying to have you fix their dementia. So when you say, here's something that will slow it down, then cha-ching, it's like, okay, well, there we go. And some people are coming in with some awareness and they want to see, well, how can we manage these symptoms? And then other people are coming in. The reason they've come in is because there's a quote unquote problem behavior. And so they're trying to get this problem solved. So it's a particular problem that we're dealing with, just one element of the big picture. And sometimes it's to help to make things better. They want to know how to help and what to do to make things better. And sometimes people are coming in order to find out, where do they go next? What do I do now? Now that you've done your part, what happens next? So those are sort of the behind the scenes things I think that are important. But what we're going to do now is leave it up for a little further discussion as we move forward through the week, because we're going to actually dig into what I said I thought the top priorities should be after you figure out who you're talking to, which is, again, that idea of using curiosity. And if not you, then somewhere. So if you're not the medical provider to do that, then you got to have somebody to refer to. Just saying. So we'll pause here. Matthew, later today, I know that we are doing a bingo with Creativity Connection Cafe. So we will be doing bingo with creativity. That will be Cheryl, who runs our bingo. She's into the numbers. I'm into the other brain stuff. So we'll be doing that this afternoon at 3:00. If you're interested, just check. I believe you can sign up on our website at this point in time. I'm knocking on wood. Last time we checked, it was working. We've done our conversion and we're still having a few issues, but it's getting better. And we hope that how you move around on the site is a little easier than it used to be, because we now have, you don't know it, but we have several sites which allow us to better manage content and meet people's needs and make sure we're serving different audience as well. So anyway, that's what we're up to. And Matthew, anything else?
Yeah, Teepa. So we're going to get to see the rest of Dr. Kanal's courageous conversation on Wednesday. So we'll post the part 2 as a premiere that everybody will get to see at 10 a.m. Eastern on Facebook, and then 10:30 a.m. Eastern on YouTube. And then right after that, the third part will post, not as a premiere, but just post so that you can watch it and see that third part. And then we will have Dr. Kanal on with us this week on Friday. She's going to join us during our live session on Friday so we can do a follow-up on her courageous conversation. So if you guys have questions, please put those in.
Bioimaging, that's the company that she works for, the company that's really working hard on trying to get bioimaging more real. I guess that's more real, out of the research realm and into the clinical realm. And to do that, you got to do the research to make it clinical. So anyway, so we'll be talking with her on Friday after we finish the conversation we started. All right. Well, we hope everybody has a great rest of your day. We're off and going. The sun is shining. That may be a good sign. We'll see what the temperature is in a few minutes and see where it goes. We'll see you again tomorrow, and we will have our second installment this week on, so after the diagnosis, what are you looking for and what should happen? So you'll see at least what Teepa thinks maybe, and a few other people too. All right, everybody, take care.
Bye, everybody.